Welcome everyone to the fourth panel of the Cell Press Inclusive Language Speaker Series focused on the language we use to describe the spectrum of health, disease, and disability. I'm Amber Mueller, an editor for Cell Metabolism, and I will be the moderator for today's seminar. Video recordings of the previous three inclusive language panels on sex and gender, visual communication, and race, ethnicity, and ancestry are all available on our website. This session is being recorded and will also become available online. After the event, we will be sending out a survey and would greatly appreciate your feedback. The broad goal of the Inclusive Language Speaker Series is to provide our editors and employees with the awareness and perspectives needed to make the language of scientific publishing more inclusive, accurate, and precise, while protecting against harm from the use of stigmatizing, inaccurate, and exclusionatory language. Today's panel will consist of brief introductions from our three speakers, followed by a question-prompted discussion. Toward the end of the panel, I'll open the discussion up to include questions that we source live here today. So please feel free to ask your questions as they arise using the question and answer Zoom function. Our three panelists today are Amy Oulton, a Tedx speaker and disability inclusion advocate, Vicki Mooney, Executive Director of the European Coalition for People Living with Obesity, and Dr. Fatima Cody Stanford, a physician and public health expert. Thank you all for joining us today. Also, a huge thank you to Madeline Myers and Isabel Goldman, who have helped develop this series and are working behind the scenes today to ensure that the webinar goes smoothly. To kick things off, our first speaker, Amy Oulton, will introduce herself, her perspective, and define a few terms for us to aid in our discussion. Amy, take it away.
Thank you. Yes, hello, my name is Amy Oulton. I'm a equality, diversity and inclusion speaker. And today I'm bringing my lived experience of physical disability, chronic physical and mental health conditions and neurodivergence to join this discussion and contextualize some of the reasons why language in healthcare and research matters, and to talk about some of the ways in which we can attempt to avoid harm with our choice of words. I think we all know that language matters, and we probably all have terms that we would find offensive if used towards us, regardless of identity. For many people, the terms found most offensive are the ones that the vast majority of people would agree are offensive, and so we don't have to deal with hearing them much. However, our choice of language is often shaped and informed by what is considered the default or the norm. And for the people who sit outside of this perceived societal norm, the ability to say what causes offense often does not get to be defined by the group of people it risks causing harm to. So for many minorities, they end up having to hear things that communicate, however subconsciously, that their identities, lives or rights or how you feel about them don't really matter. It's particularly important when we're considering the language used about disabled people in healthcare and health research. Once upon a time, not even that long ago, the standard was that doctors were very removed from their patients, medicine was paternalistic, and patients didn't have the same access to their medical files that we do now. Additionally, before the digital revolution, I would assume that the average person was not stumbling across medical journals and research papers on their lunch break. Shifts towards more collaborative healthcare, wider availability of information and less impersonal trials means that patients are now more likely to be confronted with harmful language used about them or about people like them. Not only does that undermine the healthcare relationship, but each patient is a person with feelings, like me, who deserves to be protected from harm. I'm going to briefly introduce a couple of concepts and a couple of terms that underpin some of the ways in which disabled people contextualize their own experiences to help frame the rest of these discussions. I just wanted to add, though, that I may use the term disabled people, but unless otherwise specified, I'm including those with chronic physical and mental health conditions, neurodivergent and deaf people here too. So firstly, I wanted to explain the social model versus the medical model of disability, although there are other models. The medical model looks at me and says, you can't get up that flight of stairs because there's something wrong with you and we need to fix you. And because you need a wheelchair, you can't get up those stairs. The social model, in contrast, looks at the same situation and says, the problem here isn't your wheelchair, it's really the stairs. If we had just built a ramp, then your wheelchair could get up there. That's not to say that the social model doesn't believe in medical care. It just puts the onus onto society to remove access barriers, rather than expecting that every individual can be cured or changed in a way that allows them to conform to a society that makes no changes for them or changes to include them. Ideas that perpetuate the medical model are harmful because it makes the lack of inclusion a problem that lies with the person who is excluded, rather than seeing exclusion as a problem worth everyone's effort to solve. The other thing that I wanted to cover in a very, very cursory way are the terms impairment and disability. Impairment is a word that I wouldn't recommend you using outside of this kind of very specific discussion, because it can immediately feel very negatively loaded, and I don't think it's a term that disabled people generally use outside of the context of disability theory. But very loosely, impairments can be thought of as the functional limitations an individual might face within themselves. Perhaps more simply, the medical condition someone has or lives with. Under revised theories, the definition of impairment is widened to make sure that it includes people whose difference is not considered a flaw, but is not traditionally accepted by society. For example, autistic people don't have anything wrong with their brains. They're just wired in a different way, but society at large does not see it this way. And on one hand, impairments do cause a lot of pain, fatigue, distress, or limitation in their own right. Conversely, some people may not feel that they are really limited by the impairment itself. For example, deaf sign language users communicate with each other with a shared language and a culture that they're proud of. Disability, compared to impairment, is something that is done to people. Disability is the social oppression or exclusion that occurs because of a lack of acceptance or accommodation of an impairment. It could be a lack of subtitles on TV programs that actually disabled deaf people, or prejudice from an employer that disables those living with depression. The reason that I think it's useful to understand the difference between impairment and disability is that whilst many people have some knowledge of the social model of disability and may feel that they're in support of it, these two concepts are quite often confused. In a healthcare and research context especially, hurt may be caused when someone proudly claims an identity and it is communicated that this is just seen as an impairment to cure. But equally, it might be most appropriate to discuss a person and the impairment that they live with, rather than applying dominant labels to patients, especially when those labels are really stigmatizing, such as alcoholic or obese. It's vital for clinicians and researchers to understand that the condition itself is not the disability, and both usually coexist. And to truly understand the patient holistically, you should consider both the impairment and the disability applied by society in response to that impairment. because the language that you choose can communicate more than you realize or may intend to. And, for example, when you discuss risks relating to conditions or use terms like suffers with, you are potentially only implying that the impairment is the problem. However, the individual may feel that the reality of the socially constructed disability being just as damaging to their overall health is being missed by the people that they entrust their healthcare decisions to. You possibly even confer the weight of social oppression of disability onto the impairment and therefore the individual themselves. As you can see, the language we use is incredibly nuanced and also fluid, and there's not one single rule to apply. For that reason, I think we do have to acknowledge that sometimes we do unintentionally get it wrong. But actively engaging with and involving the community or the individual you're discussing can help establish the preferred language to help you communicate respectfully. So I will now hand you back to Amber and the other speakers to continue this conversation. Thank you.
Thanks so much, Amy. That was really helpful. I think there's clearly a lot for us to think about and discuss. But before we dig in any further, let's hear from our next panelist, Vicki Mooney. Vicki.
Thank you very much, Amber, and thank you, Amy. I really took a lot from that. I think as I sat here and I looked at some notes that I'd put together for this, I've kind of decided to throw the notes away and actually speak as the person I am, who is a patient. So I'm a patient who has lived with obesity since childhood, as long as I could remember. I grew up with two younger brothers who we all, unfortunately, lived in a working class area. So, that area that you had the same breakfast, lunch and dinner every day. We had porridge for breakfast, myself and my two brothers. We had the same packed lunch and we had the same dinner. I suppose treats and things like that were not something that were widely available to us. But yet I was the one in the family, just like the other females in my family, who carried a lot of weight. Unfortunately, while my brothers played toy soldiers, actually, I was the girl who was out playing tennis with my friends. So I was a little bit more active and unfortunately ate exactly like them, but I had obesity. Later, decades later, I come on to learn that it's genetic obesity. But I was a girl who was stood in I suppose in Ireland, we would call it a PE class, a physical exercise class, on a Thursday morning. 9:15 every Thursday morning, and I would look at my feet with tears in my eyes, knowing that because of how I looked, I would not be picked for the team. I was always the last person to be picked. I was the girl who sat at the back of the class, who didn't raise her hand, because in the 80s, they didn't really have uniforms in XXL or 4XL or any of those sizes. So when you're physically not fitting into your clothes, you don't really want to be the one, making, or I suppose, drawing attention to yourself. And the reason I bring this up, and you're probably wondering, what does this fit with language? Well, throughout my childhood into my teenage years, as people called me lazy or sloppy or, non-adherent, I was told by my guidance counselor that I was not academic, so therefore I should apply to a local factory for a job, which I did. My very first job was as a glassblower and sheet metal worker. I believed what I was defined as an obese woman who was everything that everybody said: lazy, gluttonous, silly, stupid. I was the people pleaser. I would say yes to everybody and everything. And that actually, unfortunately, I allowed that, like many other people, to define me as a person. So when it came to hearing the word obese or being, lifted up by the ambulance crew and, oh, we got the fat one this time, I actually allowed that to define me as a person. Now, it's only later that we realized that, hold on a second, well, WHO actually identified obesity as a chronic relapsing disease in 1948. We now know that it is actually a relapsing chronic disease. So therefore, I have a disease. I'm not obese. You wouldn't say to somebody who has cancer, they're cancerous. So it took a long time for me to actually realize that there was an issue with the language. However, I can also resonate a lot with what Amy said. And I do have a 2-minute video that I hope Amber will be able to play now, and then I'll come back for about a minute or a minute and a half more.
So an average morning for me would be waking up in bed. After lying overnight, I have aches and pains, especially in my lower back. The thought of having to get out of bed is a struggle.
When I traveling with public transport to my work, I usually feel that I am judged.
At work, they don't know my name. They all know me only as the fat construction manager.
People notice you and they stare.
Society, they're gonna give stigma no matter what. If you're not looking like this perfect person as they see on Instagram, we not all look like each other.
It's all day, every day. And then you wake up the next morning and it starts again.
I love to cycle.
I love swimming. My life is swimming. I teach swimming.
Painting. It's my new hobby, and I paint like a 6-year-old. I draw like a 6-year-old, but I'm having so much fun with it. I love it.
I'd love to see people change their judgments, to just take 1 second to pause before you speak.
People, if they were educated and understood what obesity was, perhaps maybe they wouldn't judge and shame people and they'd support them instead.
Let's actually have an aligned language, one that's mutually respectful. It is a disease. I have obesity. I'm not an obese person.
Thank you very much, Amber. I appreciate you playing that. The reason I wanted to show that video is because it's a journey that myself and my colleagues went on. Many of us have had that experience of being labeled as our disease. And when it comes to obesity, it's a very different area to many other areas, such as cancer, I believe. However, I also am a mother of 3 children. 2 of my children are neurodiverse, and my daughter is 16 years old. Now, she's 16 years old, but she has, I would imagine, the emotional, according to her therapist, emotional and social kind of identity as about 11 years old. Now, she strongly believes that she is an autistic girl, and she would be insulted if somebody referred to her any different. Now, this is part of her journey. And as I've had conversations with my daughter, and I try to explain to her that she is a person who has autism, she's explained to me that her autism makes her unique in this world. And her creativity that she has, which she believes is her superpower, makes her unique in this world. And as a mother, that makes me step back and reflect on my own experiences and my daughter's experiences and her words. And I think I go back to what Amy said at the very end. This is about respect. This is about being respectful to the person, but this is also about identifying with what the disease is. And I know that when Fatima comes on, she's going to actually give us a fantastic few words on it. But for me as a person, I do prefer to be spoken to as a person who has obesity, as well as many other NCDs, unfortunately. But for my daughter, she prefers to identify as an autistic young teenage girl. So I'm looking forward to the discussion, and I will hand back now to Amber.
Thanks, Vicki. Even more for us to consider and discuss later. Just a reminder to the audience to ask your questions using the Q&A prompt at the bottom of your Zoom screen so that we have lots to discuss later in the panel. Last but not least, as our third panelist, we have Dr. Fatima Cody Stanford. Fatima, the floor is yours.
Thank you so much. I am delighted to come after Amy and Vicki. I think that what I have to say is very complimentary to both of them, and the delight is just mine to come after two patients who've had the opportunity to share their voice. My heart goes out to them, and my goal as a clinician, as a physician scientist, is to support their work, to support their voice. And so I will have a few slides to share as we really kind of move forward. So I'm going to share my screen here for a moment. And don't worry, I won't be doing an hour-long presentation, so don't worry about that. But I do want to talk about the inclusive language of those with obesity. And Vicki really set the stage for this as we really get into this conversation of the words that we use when talking about those with the most prevalent chronic disease in human history, which are those with the disease of obesity, the disease that I treat, the disease that I investigate. And so I'm delighted to be here to share my perspective as the clinician, as the physician scientist. So I really want to start talking about this from the lens of looking at bias in Western society. I'm going to talk about this from the lens of the United States and talk about the two most common forms of bias that we actually see here in the US. And those two common forms of bias are actually race and weight bias. I'm going to start by looking at race bias. And as you might have wondered or guessed, I am a Black woman, a descendant of the enslaved here in the United States. And if you did a search for young Black boys, I just did a Google search back in 2016, not too long ago, to just do a search for them. The search algorithm in Google returned mugshots of just young Black boys, much like what you see on my screen here. But if you did the exact same search for young white teens, you saw pictures with smiling faces holding things like a soccer. And I know, for example, we have those from the UK, and so that's considered football there. But an American football, for example, basketball, and kind of in smiling groups here. When this story ran in the Washington Post in 2016, you can imagine that Google did change their search algorithm to remove the bias that was inherent in their search algorithm. And so we have race bias, the most common form of bias that we see here in the United States. Now, I want you to look at the right side of my screen and look at the bias that we have. And Vicki touched upon much of this bias that we have when we look at those that have certain body types, those that are lean, those that carry more excess adipose. Adipose is this fancy word, this organ that is fat. And so we do look at people and we have judgments that we accord to them based upon their size. So if someone happens to be lean, we think of them as vain or superficial, ambitious, conceited, confident, mean. But if someone happens to carry this excess adipose, much like Vicki told us, they're lazy, giving, insecure, undisciplined, careless, passive, or even nice. These adjectives that are used. She talked about her PE class. She talked about things that were accorded to her just based upon her size. These biases that are entrenched and actually start quite early in life. And so you're wondering just how early do they start? So I wanted to bring up this data point that may be surprising to you to just determine how early in life do these biases about one's size, how early do they start? So this is a study that was published back in 2016, looking at mother and child dyads, so mother and child pairs, and they looked at older infants, about 11 months of age, and they found that at 11 months of age, they actually had a bias at looking at figures that had obesity. But by 32 months of age, not 32 years, 32 months of age, they actually preferred looking at much leaner figures, and that this bias was correlated with maternal bad attitudes. Now, when I mention this to parents, they often say, well, I don't say anything negative against persons that carry more excess weight, but it's also those nonverbal cues that we're using. So let's say you're sitting down with your child and you are always commenting positively about someone that's lean and never saying anything positive against someone that carries more excess weight. You are saying to the person, without saying it, that that person is not as desirable. And so this happens very, very early in life. And it really shapes the conversation. It shapes the thought process very early in terms of what we believe about those that carry more excess weight. And so let's think about how this influences those that actually care for individuals, the care providers, the physicians of the world. And so I wanted to share with you a study that was performed here called the Changes Study, looking at medical students and the bias that they have when they actually care for individuals. So in this study, this was a study looking at medical students that were enrolled in medical schools here in the United States. And they looked at both those enrolled in both public and private schools throughout the United States. They looked at about 1,800 medical students at their first and fourth years. And for those of you who are not aware of our system, we do have 4 years of medical school. So this really looked at the full medical school history. So from the beginning to the end. And what they did was they looked at surveys looking at weight bias, medical school experiences, and climate. Now I want you to see what they found with regards to implicit bias and explicit bias. And let's just look at the differences between those two. Implicit bias is the bias you don't know that you have. That's that bias that's intrinsic to you. Explicit bias is the bias you know that you have towards individuals that may carry excess weight. And they compared this towards the public. So the public versus medical students. Now, I want you to see that over the course of medical school, the 4 years of medical school, the public remained about the same, and implicit bias did appear to change. So it seemed to go down during the study. So that's really refreshing. That seems like medical students' implicit bias can change over the course of medical school. But before you get really excited about the study, I want to show you the next slide. And in the next slide, you can actually see that while the public stayed about consistent, that explicit bias, that bias we know we have towards individuals, actually increased during medical school. This is really disturbing. It shows that our bias towards those that we're supposed to be caring for, I just told you that obesity is the most prevalent chronic disease in human history, it actually intensified during the time of medical school. So instead of getting better, we actually got worse. I wasn't in medical school then, I was beyond medical school, but it shows that we are modeling negative behavior. The same people that are supposed to be helping you are actually providing harm. And you might be like, well, how are we providing harm? We'll get into that in a subsequent slide. And so these were some of the conclusions from this particular study. Medical students may reduce weight biases by increasing positive contact between students and patients with obesity, eliminating unprofessional role modeling by faculty members and residents, and altering curricula focused on treating difficult patients. Now, I didn't like the idea of them using difficult patients here because it implies that persons with obesity are difficult, and I like that as an attribution, and you can understand why that might be. Now, I really love this diagram. And this is why I told you this is really important for us to consider. Because when we're thinking about weight stigma and the treatment of obesity, we have to recognize that if the interaction in the healthcare system is negative, it's going to actually lead to poor health outcomes. And so why is this? This is coming from Dr. Rebecca Poole, who's one of the leading experts looking at weight stigma. And I really wanted to share this with you today because I think it's important for us to recognize that if a person is experiencing weight stigma, this actually leads to stress, which affects eating and physical activity behaviors. We see binge eating, increased caloric consumption, maladaptive weight control, disordered eating, lower motivation for exercise, and less physical activity. Well, believe it or not, this leads to physiologic changes where we see increased levels of cortisol, C-reactive protein, hemoglobin A1C, and elevated blood pressure. So this actually leads to internal changes within the individual. Well, this affects healthcare services where we see poorer treatment adherence, less trust of us as healthcare providers. That's no surprise. Avoidance of follow-up care, a delay in preventive health screenings, and poor communication. All of this subsequently leads to weight gain, which then affects the psychological health and distress of an individual. We see depression, anxiety, low self-esteem, poor body image, substance abuse, and unfortunately, even suicidality. This is a vicious cycle, which then leads to physiologic health and distress, where we see poor glycemic control, less effective disease self-management, more advanced and poorly controlled chronic disease, and then unfortunately lower health-related quality of life. So there's this major cascade of events that happens when someone experiences weight stigma, and when that weight stigma comes from those that are supposed to be a trusted resource, those of us that are supposed to be providing healthcare, you can imagine how this sets up a negative interaction with us in the healthcare setting. So I can tell you that I've worked with organized medical organizations to help change the language, that language that Vicki talked about. And I can tell you that we, in 2017, the American Medical Association, changed our language such that we encourage the use of person-first language. That means patients with obesity, patients affected by obesity, and all discussions, resolutions, and reports regarding obesity. We encourage the use of preferred terms in discussions, resolutions, and reports regarding patients affected by obesity, including weight and unhealthy weight, and discouraging the use of stigmatizing terms, which include obese, morbidly obese, and fat. And we educate healthcare providers in the importance of using person-first language and treating patients with obesity, equipping their healthcare facilities with proper size furniture, medical equipment and grounds for patients with obesity, and having patients weighed respectfully. Now, subsequently, I've also worked with the international environment. And just on October 17th, so the timing could not have been better, just a month ago from today, the World Obesity Federation released their position statement on recognizing and reducing weight stigma. I happen to be one of the authors of this piece, and we have worked tirelessly to think about this from a worldwide perspective. We want to distinguish between body size and obesity. That's one key tenet. Promote human rights-based approaches to tackle weight stigma and discrimination, to increase the global evidence base, to consider individual language preferences. We've heard some of these nuances covered today. To use non-stigmatizing language and imagery. Have you ever thought about when you watch a news story and you see, for example, individuals with obesity where their heads are cut off, stigmatizing figurines where they're only engaging in slothful behavior, eating pizza, things that are not reflective of what Vicki tells you. She says she was an athlete. Why do we not see that depicted in the pictures? Using person-first language, which we've already talked about, engaging in weight-neutral health promotion, raising awareness of weight stigma, and engaging in legislative and policy efforts to reduce weight stigma. So like I mentioned, this was just a month ago. We began planning this particular conversation well before this, and I'm happy to see these efforts continuing. I am dedicated to this work. We are dedicated to this work. We must treat patients with obesity with the dignity and respect that they deserve. I do want to thank you for your time. You can feel free to follow me on social media, on LinkedIn, Instagram or X, Twitter, whatever you guys want to call it, at Ask Dr. Fatima, and I'm happy to engage in this conversation with you today.
Thanks. Thanks so much, Fatima, and thanks to all the speakers for your perspectives and for introducing some really important themes for us to think about. I want to move to the question prompted discussion now. So let's start off with Amy. Going back to your experiences with disability, can you talk a little bit about the term ableism and how that's harmful?
Yeah, so I was looking, I was unmuted. So I think ableism is the same as any other form of discrimination, really, in that sense. I think that there are kind of two components to it, although they both feed into each other very much. One side being the kind of individual, and we've talked about sort of implicit and explicit bias, and there's a huge implicit bias towards disabled people, including from disabled people themselves. And that feeds into how we treat other people, the assumptions that we make. You know, if a candidate comes in for a job, have you immediately discredited that they could do the job without checking that assumption? It also covers, you know, at the extreme end, outright obvious discrimination, hate crimes, things like that. But then there's also the kind of systemic level, which is the things that we're talking about here around, you know, not having a bed that is large enough to accommodate the patients that are there, or cervical screening levels are incredibly low in England, at least, for patients with physical disabilities who can't transfer themselves to like a bed for a check. And those kind of levels where disabled people are just not considered. And those policies from institutions, governments, whoever, they end up impacting on disabled people because they're not given the full chance to participate.
Thank you for that answer. And for this question and all of them, if any of the other panelists have anything to add, you're please encouraged to participate. If not, I have my next question is actually for Vicki. So how has inclusive language positively impacted the mental health and well-being of individuals with chronic conditions or disability?
One thing that I didn't actually mention when I spoke, and I deliberately left it, is because some people look at me and go, well, she doesn't look like she has, you know, severe obesity. At one point in my life, I was tipping 200 kilos. I've had, in the last 2 decades, various treatments, surgeries, and everything else to manage my obesity. Now, what I realized when I had my first treatment in 2005 was very quickly, within 1 year, I lost half my body weight. And even the cashier in a shop treated me differently. People looked at me and spoke to me differently. People, instead of actually saying, you're a pretty girl, if you would lose weight, it would help, people said, wow, you're a beautiful woman. Even something like that. But I actually had spent, unfortunately, my childhood and my teenage years, which are the most critical years for a person, listening to, I was fat, I was too lazy, I wasn't doing enough, I'd failed, I'd eaten too much. And that language actually started an internal conversation in my own brain, which we call internalized stigma. And that internalized stigma led me down the pathway that Dr. Fatima has shown you. I became depressed. I started comfort eating. I felt I wasn't good enough. But when I had treatment and I lost half my body weight, and I then went on to become the first plus size model in Ireland and start working in television and media, people spoke to me differently. And I suddenly felt like I was like Superwoman. I could not believe the empowerment I got from that. However, I realized, I would say in the last probably 10 to 12 years, it's a very superficial empowerment because I was banking on the outside world to tell me what I was, rather than listening to my own inner voice saying, I'm an intelligent human being. I'm a kind-hearted woman. I'm a great mother. I'm a great friend. You know, I did my diploma in psychology because I thought when I lost my weight, oh my gosh, I am academic. And then I realized I've had a really traumatic childhood because I was treated so badly because of how I looked. So how you speak to a person, the impact on their mental health, I cannot explain to you enough. I started as a glassblower, believing that because of how I was spoken to and spoken of, that I wasn't good enough. I'm now the CEO of a European organization working amongst 36 countries in Europe. And I cannot tell you enough how important it is to get the language right, but the language has to suit the individual as well. Many patients who have obesity, they don't want to recognize it. They're like, oh, no, it's my fault. They blame themselves. And that's because of that societal narrative that we need to remove. So be gentle with people, be respectful with them, work with what they need, and try to change that language as much as you can.
Yeah, can I add to that?
Please.
So just to add that my journey actually is very similar to Vicki's. through my teenage years, I had bariatric surgery at 21. And I don't think it's a coincidence that I started to receive proper medical care for my other disabilities and chronic health conditions that had been there all along, but had been just ignored. I was once told that I would have fewer allergies if I lost weight because I would be able to breathe more deeply, which I don't think is science, but I'm not a scientist. And I did lose most of my weight, and it has been coming sort of back on again recently. It's 10 years, and I'm lying about my age, since I had my surgery. But the things that I'm worried about with the increased weight gain is the way that I'm going to be treated by doctors, and whether that is going to prevent my access to healthcare, or whether it ends up preventing my access to healthcare because I choose to prevent my access to healthcare. And I would say that actually the same thing very often applies. I feel the same stigma around wheelchairs. That comes up a lot. And certain medication usage as well become real barriers to accessing healthcare. So I just wanted to speak to that as well.
Yeah, I want to jump in. Well, first of all, there's a common thread here. And that common thread is this excess weight, which was a barrier that prevented the medical community treating people the way they should have been treated, because obesity is a disease you wear. And having a disability is a disease you wear in a different way. People often are kinder to persons with disabilities. They often, offer a helping hand. But if a person carries excess weight, people feel you deserve it. Oh, you deserve your fate. So, I'm not going to help you with that because you put yourself in this predicament. They don't know why, but they really feel you deserve it. We disagree with that, right? That's why we're here to speak about this, but that's that bias that we talked about, that entrenched bias that started at 32 months of age, that emerged and reflects what those medical students that go on to become those doctors or other healthcare providers really believe and feel. And so I'm going to come to a question, and actually, Amy, this kind of reflects on some of your latest portion of thinking about medications. We can't get away from the new medications. I can't get away from them. I do at least 10 interviews a week about the new medications, which are what we call the GLP-1 receptor agonists, or glucagon-like peptide 1 receptor agonists. They work on the brain. So I'm going to tie this into another question that I saw in the Q&A about why is obesity a disease? Why are we calling it a disease? Like, did the three of us just make this up just because we wanted to make ourselves feel good about ourselves? No, it's not. So the reason why we call it a disease is because it actually relates to dysfunction within the body. And the primary organ that regulates weight is the brain. And so let's talk about the brain and how the brain regulates weight. There's two primary pathways that regulate weight. There is a pathway of the brain called the POMC, or the pro-opiomelanocortin pathway. That's our anorexigenic pathway of the brain. It's in the kind of the right side of the brain. It stimulates our desire to not eat. And then there's another pathway of the brain called the AGRP pathway, or our orexigenic pathway of the brain, that tells us to eat. These medications work to stimulate the POMC pathway and downregulate, which is the anorexigenic pathway, and downregulate the AGRP pathway, that pathway that tells us to eat more. So there's actual pathophysiology in the brain that communicates with the periphery, the gut, and different hormones in the body that dictate this disease process. Now, different people have different dysregulations that lead to us having obesity, and that's an entire hour-plus long segment that we don't want to get into. But the reason why these medications, I think, have taken off in the way that they have is because it works on that primary pathway in the brain. So the question that came up in the chat is, do we see this impacting stigma, this idea about vanity use, and people using them for vanity versus using them to actually treat medical conditions? This dimorphism, I think, is problematic because we do have this unfortunate issue where people that really need the medications aren't getting the medications, and people that do need the medications aren't getting them. There has been a vast shortage of these medications that has really been pervasive throughout the world, whether you're in the UK, whether you're in the US. I did an interview in Bermuda yesterday, so it's everywhere. And there is a bit of a issue also with socioeconomic status. So those that have more means are able to access these medications more than those with lesser means. And so there is that issue. I think this is setting up this tug of war between the haves and have-nots. It's also setting up this dimorphism of pitting one disease process against another. These medications are approved and often covered for those with diabetes and not covered for those with obesity. Is as if we think that obesity is not a disease and a diabetes is a disease, which then creates an entire process that I don't agree with, which is another hour-long discussion that we can get into. And so we have this back and forth, this tug of war that goes back: is this a disease? Is this not a disease? Why is this covered? Why is this, not covered? Why do we not care about these people that have lower socioeconomic position versus these people? And I think it shows that we are stigmatizing this group versus this group when we look, for example, at those with type 2 diabetes. 80 to 85% of patients with type 2 diabetes happen to also have obesity. So we have these kind of going dialogues. And so these are things that keep me up at night. These things get me fired up. But these are things that I'm willing to fight for my patients, those that have diabetes, but those that have obesity, and making sure that they get access to therapies that are willing to that are useful to treat their disease. So that's my soapbox moment for that. And I'll take a deep breath. That's what I'll do.
I think that is actually a trend that is, in my experience, very common, certainly in the UK as well, between the haves and the have-nots around a better wheelchair means. I mean, I hate to always bring it back to wheelchairs, but that there's so many things that you could buy. I personally went through a private diagnosis for my ADHD because I was in the middle of a mental health crisis and I needed to do that. But most people, I was told the waiting list here was 3 years, so there's that same have and have nots, and that's the disability, that's the systemic ableism of the systems that we've created, whether that be insurance companies or what's funded on the NHS or wherever we're talking about. It's I think it's kind of all one thing, one goal in many ways.
Yeah.
And actually, I just wanted to just comment there, Amy, when you had actually spoke about weight regain as well. This is another area where the language is so important, right? Because I had weight regain. So I had bariatric surgery. I lost half my body weight. I was all over TV as a plus size model, doing fashion, and opened my own plus size modeling agency. I became so empowered. 6 years later, I'm still eating the same. I'm exercising more than I ever did. I'm dancing every weekend with my friends and my girls. I'm doing Zumba classes, and I start to regain weight. And I cannot figure out why. So here comes the self-blame again. And then you have people saying, oh, what happened? How did you regain all of that weight? I regained like 60 kilos in a matter of years. And that conversation that takes place in society and with healthcare professionals, that's one that really needs to shift, because the patient does not fail. Treatments fail patients.
Absolutely.
Patients do not fail. So when you talk about regain, it's important to actually not use any stigmatizing language around that as well. But I just noticed as well, and I'm just going to very quickly throw in my tuppence word on this. In Ireland, we say twopence, but it means 2 cents. But somebody mentioned about media and the images in media in Europe. And I know our colleagues in OC and OAC, we've all created media image banks that are free to use for
those in the chat for everyone.
Exactly.
So yes, and then for the weight regain, that's all the science. So what people don't realize is that there is a honeymoon period after bariatric surgery. Hormones like ghrelin, which is the main hormone, that's a hunger hormone, that decreases in the first 6 to 12 months post-surgery, but it starts to rise GLP-1, which is a medicine we give, but it's actually housed in your body. It actually goes up after surgery, but it starts to go down. All of these hormones change. And as the further you get from surgery, they start to reemerge. So one of my major areas of research is showing that reemergence and showing you how if we add medications, we can prevent that regain. But that's another story for another day, another hour-long lecture, and I can send you guys the papers. But I did put all of the images in the chat from the Rudd Center and from the Obesity Action Coalition, which are images that don't depict individuals with obesity in stigmatizing ways. So that's really important. I saw another image or question about BMI and the issue with BMI.
Sorry, before we get to that question, I just we've been focusing a lot on obesity, which is a very important topic, but I want to kind of get back to language in general and also specifically in scientific publishing. So this question is for all three of you, but we'll start with Amy. So how do we involve individuals with disabilities and/or chronic conditions in shaping the language and discourse surrounding their healthcare experience? So either in the doctor's office or in scientific publishing, who do we go to?
Yeah, so I did see someone kind of raise the fact of some people will prefer person first language, some people will prefer identity first language, and it is an individual thing. I think that having that conversation, if possible, doctors are incredibly limited for time, but the more that conversation could be had, because it just immediately signifies to your patient that you at least want to try to be respectful. As I said, we do all get it wrong, but you have signified that there is respect there, and so I think that's really important. I think on a sort of wider level, if you're thinking more about policy or research journals and things like that, trying to speak to people with those conditions, going to organizations who may kind of work. But when I say organizations, I specifically mean user-led organizations and not organizations who may speak on behalf of people with those conditions. And then actually, I mean, I guess we had a long conversation about, in terms of research journals, there's so much that you have to sort of justify, I guess, you in your methodology, like, why have you done this and not this? And actually, the more that there can be a move towards justifying the language that you're using, in whether that is in research journals or in publications or in leaflets that you give to patients, whatever, like just creating that awareness, because so much of the problem with so many of these issues is that they're very hidden, and it kind of just makes people think, oh, should I be thinking about disability? Should I be thinking about chronic health conditions? Should I be thinking about obesity? So that would be speak to people.
Yeah, and I think it's a very new thing as well, right? 2-3 years ago was when we really seen here over in Europe. I know our colleagues in OAC and that, and Obesity Canada had engagement from journals and authors, and finally asking the question of how do we actually speak properly, and that's a real challenge for healthcare professionals, no matter what disease area it is, because it's very delicate. It's a very personal thing to patients, and like there's a lot of materials out there now, but include your patient, include the person that it affects, because they will happily speak to you about it. And I know, Fatima, you've had this experience so many times, right?
Absolutely. I was trying to get myself off mute. So I will make sure that, for example, I review for over probably 70 journals. If it does not have the appropriate language, I will reject the article. So I will not even review the article. I will send back to the editor, say, I will not review this until the language is changed. I will not review it. It could be a landmark article, but I feel that the author should be more thoughtful in the language that's being utilized here. They can go back and change the language. I will review the article and, give it a great look. I think if we continue to do that, if persons like myself are doing that from the academic side, and this is, these are top line journals. These are, the Cells of the world. Why are we not emphasizing that? There are several journals that will do a desk reject for lack of person first language, for example, for obesity. And if we're starting to see that shift, then we'll start to get language that is respectful of individuals that have, for example, a disease like obesity. We should see this permeate so that we're respecting the individuals that we're speaking about and not just treating people as if there's some distant subject that we're writing about. And I think that we have to be thoughtful in that of individuals when we're writing in that way.
And can I just add one thing before, Amber, you take over, and I know we need to wrap up soon, but as well as that, I'm looking at the screen, we've got 3 white ladies and we've got 1 beautiful Black lady. Don't forget about culture. Our ladies in Kenya, when I contact our team over there and we engage with all of the community there trying to combat obesity and work together. It is seen as healthy to carry adipose tissue, to carry extra weight. So don't assume that that will apply to every language, every culture, every ethnicity, so on and so forth. And we see that problem in Europe as well, where it's very different in Eastern Europe to Western Europe. So remember, the culture is important too. Don't forget that.
Thanks. I had a question prompted to you about cultural differences, just in terms of inclusive language, but I appreciate that you covered it. I think it's time for our wrap-up question. I want to leave. We've kind of opened the floodgates here, and there's so much more to discuss. So I hope that we continue this conversation. But I wanted to kind of get back to what you were all resonating around in that last Q&A is, in your mind, whose responsibility is it to make sure inclusive language is being used? And then how should language policies be informed and or enforced? 30 seconds, everyone.
Everyone. It's everyone's responsibility to make sure that this world is inclusive to everyone. It's kind of as simple as that. In terms of enforcing, that's a little bit more tricky. I think it needs to be explicit who that's falling to. I know that some places will have there's a list of sort of contentious issues or issues that may have incorrect language or harmful language used, and then immediately goes to be reviewed by people who go no and reject it. But I think the more people talking about it, bringing this up, this will change slowly, hopefully.
I agree. And, I'm not going to speak for long, but I think it's a shared responsibility. And I think now that the patient or the person with the disease or the disability is an equal partner at the table, it is most definitely a shared responsibility.
And I have to concur wholeheartedly with both Amy and Vicki. This is not on one entity. This has to be across all domains, all entities. The only way we're going to see this become pervasive in society is if all entities take responsibility for this being, permeating throughout society as a whole.
Great. Thank you so much. Thank each of you for joining us today, and thanks to our audience for helping to make this such an active discussion. I think we can all agree that the panelists have given us a ton to think about and hopefully implement across our company to make our language surrounding health and disability more inclusive and precise. So thank you all, and have a great rest of your day.
Thank you.
Bye, everybody.
Bye-bye. Have a great day.